what I called PPAC, but now our president owns the name Obamacare, so I go back and forth. It was around 15 months ago, and a whole lot has changed. Now, in case y'all don't know who I am just a doctor. I'm not a policymaker. I'm a Wahoo ×2, having gone there for undergraduate and medical school, did my orthopedic surgery training at Wake Forest, my hand fellowship at Tufts University in Boston. I'm a former orthopedic chairman. I've been a member of the Quality Committee, Credentials Committee. I'm currently a medical director of hand therapy, and I'm a member of various organizations there, most notably representing Government Affairs Committee in the American Society for Surgery of the Hand, and I'm president-elect of the Norfolk Academy of Medicine. But again, I'm not a policy University of Virginia graduate. Yes. So again, the last time I spoke was around 15 months ago. We were discussing the Trojan donkey of Obamacare. And I'm going to just share a couple of personal vignettes at the very beginning. I was trying to decide how I would present Obamacare now, and the first thing I ever wanted to be in life was a meteorologist. And I wanted to be, at age 10, just like this woman here, Janet Peckinpah, okay? And Obamacare, it really it's been like watching a hurricane approach. And so it's I feel very analogous to a meteorologist. And, that's right. And so I very much felt like Janet Peckinpah forecasting the hurricane 15 months ago, and now it arrives. And I was very surprised that I actually could find a picture of her from 1978. She was a meteorologist in Richmond. And ironically enough, some of our commonalities continue because she actually ran for Congress in the 2nd District up in Connecticut, mind you, in 2010, and lost a closely contested race. So I thought that was pretty interesting, a meteorologist turned politician. So now here we are, Healthcare 2014. The Trojan donkey is here. What I'm going to discuss today are what we're seeing, some of the early effects of Obamacare, nationally, locally, and then what I've seen, my personal observations in my practice in my life. We're going to discuss a big topic for Virginia right now, which is, of course, Medicaid and whether to expand or not. And where do we go from here? So the hurricane is approaching. The outer bands are hitting currently. And what we're seeing is, one of those skipped. What we're finding right now is that those who passed the bill are now getting to see what's in it. So Nancy Pelosi is getting to see exactly what's in this 2,000-page law. We're seeing that individuals are losing their coverage, millions and millions, and the cost for almost all others is going up. The website, predictably, is a disaster, and the administration essentially this time is trying to save face through the next election cycle by making at least 30 changes to the law so far. I'm briefly going to touch upon just a few of the administrative actions because these have gotten a lot of press and we don't need to drill down too much on this. We know that one of the administrative actions is that Congress now has an opt-out. So even though it's good enough for the rest of us, we are actually going to continue to fund their health care. They're concerned that there will be a brain drain if we don't. Instead, I think we'll see the brain drain in small business and in medicine. We've seen a delay in the individual mandate, actually of approximately 6 weeks. We've seen, of course, a 1-year delay in the employer mandate. We've seen a 1-year delay in the small business initiation of the federal exchanges. We have seen that many people, because their insurance plans in the individual market did not meet what Obamacare set out, their plans were canceled, but then you saw the administration backpedal and say, oh, no. They can offer those plans again because there was so much kickback on those individual plans being canceled. And as a result of the employer mandate being delayed for a year, when patients go to the exchanges to say, I make X amount per year to qualify for a subsidy or a tax benefit from us, instead of going through the employer to verify their income, they now can just self-attest. So you can't tell me that that's not going to be a source of significant fraud. Now locally in Virginia Beach, we've seen some headlines. We've seen how the plans for both the city and the school have shown an increase in the deductibles up to 10 times. So a deductible from $300 to $3,000, that's what it says in that tiny little red circle. And 2 out of the 3 healthcare plans that's offered by the city are demonstrating premium increases. We've heard a lot of commotion from the firefighters and from the police. They're understandably upset about this. They're also raising the tenure from 25 to 30 years. And the net result for the city is that this is saving the cities and schools $17.2 million. That's not chump change, but then the employee contribution is increasing $8.8 million, which is also not chump change. This is cost shifting. So now I'm going to discuss what I've seen more personally. And we've all read articles, but I want to tell you what I have seen. So, what my patients are saying. In December, I had a patient who came in to see me who said they wanted to schedule surgery ASAP because their deductible doubled on January the 1st. I had another patient who told me that if she had her surgery performed before January 1st, it would cost her $50. If she waited until after January 1st, it would cost her $2,000. So, this isn't just stuff you're reading about, U.S. News Report. This is what I've seen. I also had a patient who I did a thumb reconstruction on, and that's a somewhat complicated surgery. It requires therapy to maximize your outcome, but she can't go to therapy because she had already maximized her visits according to Medicare. She had had a shoulder surgery done prior in the year. She had used up all of her allotment. That will affect her outcome. So what have I seen in my surgical practice? I have seen an explosion of regulations that are imposed by the federal government and by Medicare. We have this alphabet soup called PQRI or PQRS, depending on the month, where we basically have to check boxes in our electronic medical records to show that we are compliant. I say this death by coding because we have this immense coding regulation, which actually we're coming out with a new one. There was ICD-9, now it's ICD-10, which expands the number of codes that we have to use for diagnosis and surgical treatment, and it's hard to explain in a 20-minute healthcare policy talk how that influences my ability to take care of patients. But in our charts, we have to check off certain items in order to qualify for a code to be paid. And now that's made much worse. And when I, as a surgical specialist, am looking at a primary care provider's referral note for information on why a patient is being referred for me, I would say about 90% of that primary care provider's note is noise. It's all input for Medicare or for regulations, and it's very difficult for me to glean any meaningful information about a person's hand problem or arm problem from that note. So electronic medical records, we're all now mandated to go to those, and I will tell you that increases my time in the office, and I'm pretty facile with it, by approximately 20%. And I've seen also personally when I've recommended, say, an MRI for somebody's wrist pain, there is a much greater chance that MRI is going to be denied by insurance. It is very frustrating as a healthcare provider. Now, this is I can't say whom I work for, which is why there's a strategically placed pen over the recipient of this envelope. But this is just to show, if you can't read it, it says Compliance Document Services. What in the world is that? And how does that help a healthcare provider take care of a patient? I mean, this is just one real example. I saw it on my manager's desk, and I had to take a picture of it. This is obviously causing increased strain in our staff because they're having to spend more time checking boxes and doing different clicks. And I have already had to decrease the amount of patients that I'm seeing by approximately 5% because of this alone, to accommodate for the increased regulations. Because the flip side is, if I don't, then I'll be spending an additional 2 hours per day just going through and making sure all the regulations are adhered by. And you get to a point, obviously, where it's just not worth it. This is going to decrease access at a time when we're already experiencing a physician shortage separate from PPACA. So now, of course, it's unique. I'm not only a doctor, but I'm a patient. And this is what I saw when I went to update our family's insurance plan for this year. Our premium, and there's been no change in our healthcare history, our premium has increased $600, and some of our co-pays have doubled. Now, what I don't understand, President, is whatever happened to my premiums decreasing by $2,500. Yeah, this is real life. These are my real numbers that I got, just not what we hear, what I read in a newspaper. But as Charles Krauthammer has said, what's happening is exactly as it's written. The forecast 15 months ago is just showing that the storm is hitting essentially exactly as we thought. So here we see this memorable slide just showing again the complexity of the law with, of course, Kathleen Sebelius, the Secretary of Health and Human Services, at the helm driving everything. With the IRS here, you see IPAB, the rationing board for Medicare, and you see the president right here. Oh, there are the physicians. And the patients are way over here, extremely marginalized. It's exactly what we're seeing. So now I want to discuss Medicaid, because this is something that's very real to Virginia right now. Medicaid is one of the cornerstones in PPACA of expanding coverage, and it's a leading budget item in most states. In Virginia, it's 22% of our general fund. If all states expand Medicaid, we could have an increase in numbers of 84 million. 84 million, what's that? We have 317 million Americans, so we're talking about 25% of Americans being on Medicaid. And states only receive 2 years of a fully funded federal subsidy at 100%. Then it goes down to 90%. And I just wanted to comment briefly on the federal government track record of holding true to their promises. Here's an example that was recently published where the government contracted with the Indian tribes, and I guess we might be the analogy for the Indian tribes in the future, to provide for medical services. They ran out of money and they refused to pay. So the Indian tribes sued, and this went all the way up to the Supreme Court. And the Supreme Court said, you're absolutely right, this is breach of contract. You need to pay the Indian tribes the money that was specified in the contract. So the federal government has paid some, but not all. And this has impacted healthcare significantly on the reservations. And the Congressional Research Services demonstrated or showed that the cost of unfunded federal mandates, just between 7-year interval between 1983 and 1990, cost local and state governments $8.9 billion. We can't hold that the federal government is going to keep its promise. This is just a brief map of who's expanding Medicaid currently and who's not. It basically falls along party lines of who you'd expect, the blue and the red. So Medicaid in Virginia, under our fearless leader, who I believe is getting inaugurated today. So we have two choices in Virginia currently. We can expand, plus or minus reform, or no expansion, only reform. So looking at Medicaid in Virginia 2012, we have 1 million recipients. If we expand, we're going to increase our numbers by approximately 40%. Currently, our budget for Medicaid is 22%, and if we increase in 2019, it's going to be at least 30%. This is going to crowd out items such as transportation or education, and it's not going to deliver on care. So last year, there was the MERC Committee, Medicaid Innovation and Reform Commission. There are 12 members. They met monthly to discuss whether or not to expand, and if they had voted to expand, we, Virginia, were supposed to expand. However, at their most recent meeting in mid-December, they did not take a vote, which is a good thing. Now it goes back to the state assembly. So, why reform Medicaid? Medicaid is similar to Obamacare. It costs too much and it doesn't deliver on patient care. It's an open-ended entitlement and it's been devouring, as we see, states' budgets. There's no skin in the game by patients, so they don't have any incentive to control costs. And Dr. Bill Hazel estimated that fraud in Medicaid was 15%. That's a lot. And Ken Cuccinelli's Medicaid fraud group recovered $1.58 billion in fraud. These are big numbers. And in addition to the cost, the other part is that there's poor access. In Virginia, physicians get reimbursed 60 cents on the dollar for the cost of care. Physicians can't afford to take care of Medicaid patients. Many aren't taking new ones. And we'll hear the left say that, oh, but for the next 2 years, they're going to fully fund it to 100% of the cost of care. A, that's only for primary care providers. It's not for specialists. B, what happens after 2 years? Many primary care providers aren't waiting to, they're going to jump on board to take 100% for 2 years, not knowing what's going to happen after that. That's a ruse. So Medicare is broken. And you can see here the Medicaid growth rate over the last 3 years. Virginia's grown 9.2%. We're leading in that. There's a lot of fraud. I'm going to just describe and a lot of reasons why it's broken. I'm going to give you one example of why Medicaid's broken. I spoke at the Merck Commission back in October. This is a different example. I have a friend who's a plastic surgeon, and he had a patient on the Eastern Shore with, I believe, breast cancer. And he and another surgeon operated on her doing a complex reconstruction called a TRAM. And the surgery took 8 hours for the two surgeons to perform. This surgeon's reimbursement by Medicaid was $1,600. Now, when you're paid for surgery, you're paid for a 90-day global period where that patient theoretically comes to you every day for 90 days. There's no additional copay on behalf of the patient. So this patient living on the Eastern Shore would take a cab, which was medical transport, and reimbursed at 100% by Medicaid. Okay? So we take a cab to and fro, and after 3 or 4 appointments, that cab driver got paid more for transporting that patient than the surgeon did for performing the surgery. Okay? And again, this isn't something that you're reading about in the paper. This is something that a friend of mine told me about. This is why Medicaid's broken. That's just not right. This was a clipping from the paper. This is North Carolina, but it talks about how Medicaid information was sent to the wrong patients. This is another issue with government medicine, the security of our identities, whether it's Medicaid, whether it's the IRS. Identity theft is going to be a problem in the security of our information. So the bottom line, insurance is not assurance of care. If you have low reimbursement to the physicians, you're not going to have access. It's not an assurance of care. An insurance card does not equal care, but poor access does equal poor care. So, a couple of studies. This is one actually I had highlighted back in 2012. There was a study at UVA where they looked at patients who had had surgical procedures, and they found that being on Medicaid was associated with a longer length of hospital stay, with higher hospital costs, and a higher risk of death. Now, you can possibly argue the results of any one study. Here's another study that just came out recently. In Oregon, they had a lottery to expand Medicaid. And this is a wonderful, actually, experiment. There was a lottery in 2008. and there are greater than 25,000 patients that were involved. So these are big numbers. What they found is, some patients got Medicaid expansion, or got Medicaid, and the others didn't. What they found that in 2 years, patients that had been on Medicaid had no improvement of health, but they had increased use of health care. This was later updated actually within the last 2 weeks, that they also increased the use of ERs by 40%, or $120 per patient. This adds up. And this is for all range of conditions. This isn't just for acute, but this is for subacute things that don't need to be seen in the ER. And again, I just want to highlight there's no difference in the health whether you had a Medicaid card or not. So, if you have low reimbursement to primary care providers, you're going to have an increased wait for that patient to be seen by a primary care provider. That's been seen in demonstrated in several studies as well. So instead, we'll go to the emergency department to be treated for a sore throat. Obviously, it's much more expensive to be treated in the emergency department than it is to be treated in a primary care provider's office. But hey, if I don't have to pay a copay, if it's not my money, who cares? There's no skin in the game of the patients to take any control. So we see spiraling out of control of healthcare costs. So if we expand Medicaid in Virginia, we increase the cost burden to us. There's no increased access to the patients that need it. So I want to touch upon some reform principles, and if any of you saw Speaker Howell's recent editorial, he is highlighting several of these. And this is what we need to do. Not expand plus reform. We need to see that the costs go down and the care goes up before any expansion, period. Number one, the more we can get the federal government out of the way, the better. And in a perfect world, it'd be nice to have a block grant from the federal government. Here's your money for Medicaid per patient. Do with it what you will. Because every state has different requirements. They have a different patient population, and frankly, they have different ideas. And that's where our best ideas are going to come from the state's laboratories, not from the federal government. We should not take any new federal money, and we need to figure out how to get help to those that need it. Because there's a lot of people that are getting help that don't need it. I'll briefly go off track just to give an example of this that I did present at the Merck Commission, where a friend told me about her friend. She had a friend who lived, it's in North Carolina, it's not Virginia, but I'm sure this could happen in Virginia. There's a woman who lives in North Carolina. She's very well off, many acres, has a plane. She renovated a $400,000 home on her property for her daughter and her daughter's husband and their two children. One of those children had special needs, had a disability. So the husband of the daughter, who was living in the renovated $400,000 home, the husband didn't work. He just, didn't feel like working for whatever reason. The daughter got the job of her dreams, and she was making $70 more per month than would qualify her for Medicaid. So they don't have insurance. She could drop her hours or pay to qualify for Medicaid. She's living in a $400,000 home and has a mother whose net worth is several million. Is that right? So we need to figure out how to get the help to the patients that need it, with targeted subsidies, with fraud commissions. So if there are people who are receiving benefits that shouldn't, we need to save the money and give it to those that need it. And welfare-style work requirements would also help. We need to empower patients, and we need to provide compassionate care. We need to expand our options for a Medicaid patient. So what I mean by that is, one example is, each patient could receive X amount of money, and they can either get Medicaid or they can use that money to go out into the insurance marketplace and purchase a plan. Patients need to have skin in the game. they need to have a copay, they need to have a deductible. It doesn't need to be high, but they need to think about the money that is spent. And the only way they will think about the money that is spent is if they're spending some. And we need to expand free clinics, because that can be a wonderful way to encourage charity and to provide care. We need to have cost control, which means capping the total expenditures. We need to use a defined contribution rather than a defined benefit to help control the costs. These are things like HSAs, providing catastrophic coverage, no borrowing by Virginia for this. And I just wanted to touch on what a couple of other states are doing now. There's a lot of ideas out there, but I'm only going to touch on two. In Indiana, they had something called the Healthy Indiana Plan, and patients were required to contribute no more than 5% of their income. They're on Medicaid, and the state would supplement that amount up to $1,100 and put it in an HSA for them. And what Indiana found after 5 years is they were just hoping to be budget neutral, and they saved $1 billion, and there was no change in health. There are ways to do this other than creating an increasing dependent population. In Florida, what they're doing there is they're providing their Medicaid patients with a variety of different plans, not just one Medicaid plan for all, but they have a Medicaid plan if you have, for example, diabetes. They may have more than one plan that you can choose from. And they're bringing in the private insurers. This is helping drive down the cost because there's competition for this market. They're also trying to work on more community-based long-term care, because long-term care is a big component of Medicaid in nursing homes. They're trying to transition more patients out of nursing homes and either into the home or into community centers. That's saving money too, and it's not compromising health care. That's the important thing. So where do we go from here? Here we go. This is where we're going. We're going right into the storm. Jen, Peck, and Paul. We're going right into the storm. Here's the head. And because I didn't really feel appropriate drawing analogies of myself and Jim Cantori. Here we go. Right into the fray. So we know with Medicare, we have cuts of $716 billion. We have IPAP, we'll have rationing. We see that every time we get a new estimate of the healthcare law, it's increased, it's not decreased. We're now seeing some of the new taxes hit. And we're doing all of this to take care of anywhere between 12 and 23 million uninsured. And CMS, back in 2010, said even after the full implementation of Obamacare, there's still going to be 23 million patients that aren't insured. So we're doing all this and we're not getting our goal. Let's combine this with a doctor shortage of approximately 100,000. It has nothing to do with Obamacare, and we're really in for it. We're going to see decreased access, decreased choice, decreased quality, increased weight, increased cost, and rationing, unless we can change things. So what can we do on the state level, and what can we do on the federal level? Because I don't think that giving up is an option. There are some bills coming out on the state level, both to be supported, and in a minute I'll highlight one to be opposed. But this is one of the ones, and I've heard there are going to be other ones that come up. So there's HB 39, Medicaid Alternative, and doctors donate 4 hours per week to Medicaid eligible population for primary care in exchange for malpractice coverage. And that's not just malpractice coverage to take care of those patients, it's malpractice coverage to take care of all the patients. And there's actually a similar law that's being proposed by this woman here in New Jersey. This is Dr. Alita X, who's actually now running for Congress. And she's been doing this in her practice with a significant, like 1 day a week she does just charity care. The advantage of doing something like this is that it does not involve any tax dollars. There's obviously no expansion of Medicaid. This encourages true charity. You know, I go take care of a patient. There's, I'm not trying to get reimbursed for anything. I take care of the patient. And this decreases defensive medicine. And so that is one of the options to be considered. And there will be some others that will be coming out in the next couple of weeks. But on a state level, the number one thing that we need to do is not just block Medicaid expansion, which is absolutely imperative, but we need to grab the compassionate argument and move forward with it instead of leaving it to the left. Because Medicaid expansion is not compassionate care for the needy. It's expansion of a huge bureaucracy. And we need to do things like expand free clinics, so on and so forth, that really take care of the patients that need it. Now, there are two bills I just found out about yesterday that we need to oppose. And these establish state exchanges. This would cost Virginia $110 million, and it doesn't give us any additional say. There's no advantage to Virginia establishing a state exchange. We're going to be forced to do anything, let the feds do it. While I was up in D.C. in mid-November, I had the wonderful opportunity to meet this gentleman who is, a physician rock star as far as I'm concerned. And I had the opportunity to see him speak as he received an award. And he's a big champion, Dr. Ben Carson, of HSAs, health savings accounts, because these bring control of healthcare out of the third-party payer where it shouldn't be and back to the patient and to the physician. And he actually has a plan that he puts forth, or they put forth in his talk, which says, you know what? We should give everybody, not just the Medicaid eligibles, not just the Medicare eligible, but the 370 million Americans every year. Let's give you $2,000 in an HSA. That's $634 billion, which is much less than the Obamacare cost. This money in the HSA, unlike some of the flexible spending accounts that some of us may have, doesn't go away if you don't use it. It can accumulate year after year. If you don't need the money, but a family member does in their health savings account, you can transfer it to your family member. This almost creates a little insurance company within the family unit. You can even donate 5% per year to somebody outside of your family. And the employers, should they choose, can donate to your HSA. You can also bequeath it, because we know that 40 to 50% of healthcare is spent in the last 6 months of life. And I mean, I'll tell you, if I'm sitting there not doing so well, and doctor comes in and says, okay, we can order another CT, we can order an MRI, see if your cancer spread or what have you, and it might add another 3 months to your life if we find something, we give you some chemotherapy. If I have a choice of that under the current plan where, I don't care, it's not my money, right? It's not my money. It is, but it's not. Versus if I have an HSA and I could say, gee, 3 months of life, is it worth the remaining $30,000 I have in my HSA? I'm just going to leave that to my kids. So this encourages compassion, which is really what we need. And the family accumulates wealth, and this plan gradually phases out the government. There are ideas out there. A couple other miscellaneous ideas from Ben Carson, and I'll move on. He's also a big fan of each patient having their own electronic medical record. So he gives an analogy: you could have it on your ring or a necklace or scanned onto a card. So if you're in an automobile accident and you're up in Vermont, then they can just take that card and scan it. They have your EMR. They have your electronic medical record. That's going to give you better care. It's going to save money. Tort reform is obviously a big missing piece of any control of healthcare costs, but that's another talk in and of itself. I just want to say that PPACA is not about care. It's about control. So I'm briefly going to touch upon on the federal level, because frankly, we need to get the Senate before these are viable options. But just to point out that there are alternatives on the federal level out there. This is Congressman Tom Price, orthopedic surgeon from Georgia. He has Empowering Patient First Act, and Congressman Ridgell is also a co-sponsor on this. And Congressman Price has these ideas to cover the uninsured and underinsured with these tax credits that can be used for health care insurance up to $5,000 per person. We need to bring the state high-risk pools back that were shut down by PPACA. We can cut costs by allowing insurers to sell across state lines, by allowing individuals and small businesses to pool together for bargaining power, and of course, the missing liability reform. We can increase patient choice by allowing equal employer contribution rule. What that means is that your employer can offer you insurance, or you can take that money they would spend on your insurance and go out in the marketplace and buy your own plan. Does the same thing with beneficiary choices of Medicaid and CHIP, meaning you can either be on Medicaid or you can take that money from Medicaid and go buy a private plan with any additional money that you have. So, question is, how will we be standing after the storm is passed? I'm leaving my options open.